Welcome to Reimagine Healthcare. I'm your host, Noah Volz. Here's one of the most uncomfortable facts in American healthcare. We spend more on healthcare than any other rich country in the world. By a lot. Roughly twice as much per person as comparable nations. And yet Americans, on average, die younger. Not just a little younger. Younger than people in Canada, the United Kingdom, Germany, France, Japan, Australia, and other wealthy countries that spend dramatically less. So, what is going on? Because if you only look at the price tag, the obvious assumption is that American healthcare must be wildly inefficient at everything, that it is all waste, all failure, all dysfunction. That is too simple. And honestly, it misses the part that matters most. America is actually very good at certain kinds of medicine. If you have a major trauma, a complex surgery, a difficult cancer case, or a rare disease that needs high-end specialists and advanced technology, the United States can be extraordinary. In some categories of rescue medicine, we are among the best in the world. So this episode is not a lazy America bashing exercise. It is a diagnosis. Because the real problem is not that we are bad at all healthcare. The real problem is that we built a system that is exceptionally strong once the house is already on fire, and much weaker at stopping the fire from starting in the first place. And if you understand that distinction clearly, a lot of the paradox starts to make sense. Let me start with the part people often miss. American medicine is built for intervention. It is built for high acuity care. It is built for the moment when something serious has already happened, and the question is, can we save this person, stabilize this person, extend this life? That is where advanced hospitals, subspecialists, imaging, procedural medicine, intensive care, and pharmaceutical innovation really shine. So when people say, how can the system be so expensive if outcomes are so disappointing? Part of the answer is that we are paying for a massive amount of highly sophisticated rescue capacity, and some of that capacity is genuinely valuable. The problem is that life expectancy is not mainly determined by how good you are at rescue medicine. Life expectancy is heavily shaped by what happens before the rescue, by whether babies survive infancy, by whether teenagers and young adults die from violence, crashes, or overdoses, by whether adults spend 20 years developing obesity, diabetes, hypertension, heart disease, depression, and addiction before they ever arrive in a specialist's office. That is where the United States loses ground. When researchers compare the United States with peer countries, a consistent pattern shows up. A lot of our deficit is driven by premature death. Infant mortality is higher here than in comparable wealthy countries. Drug overdose deaths are vastly higher here, especially in the fentanyl era. Firearm deaths are much higher here. And chronic disease starts earlier, lasts longer, and creates more damage here. That matters because averages hide mechanisms. If a country is excellent at keeping a 70-year-old alive after a heart attack, but much worse at preventing people from dying at 32 from overdose or at 49 from poorly controlled diabetes and heart disease, the national average life expectancy still falls. That is a big piece of the American story. And it changes the policy conversation. Because if the main problem were simply that hospitals were terrible, the fix would mostly live inside hospitals. But if the main problem is premature death, driven by addiction, violence, maternal and infant risk, metabolic disease, and social conditions upstream of the exam room, then the fix is much broader. It includes healthcare, yes, but it also includes public health, food systems, transportation, housing, mental health access, early childhood conditions, and the incentives that shape daily life. Now, to be fair, insurance coverage matters. Being uninsured is bad. Underinsurance is bad. High deductibles absolutely delay care and create damage. I do not want to oversimplify that. But even if we expanded coverage tomorrow, that alone would not solve the core paradox. Why? Because an insurance card does not automatically produce a healthier food environment. It does not stop fentanyl from circulating. It does not make neighborhoods more walkable. It does not reduce loneliness. It does not fix the stress biology of poverty. It does not make a burned out parent suddenly have time to cook differently, sleep more, exercise, and keep every preventive appointment. It does not reverse the fact that a huge share of American healthcare spending happens after chronic disease is already established. Insurance helps people access the system. But if the system they are accessing is still oriented around late-stage management instead of early prevention, we should not expect miracles. The American machine was built to treat downstream consequences. This is the deeper systems point. Our healthcare economy mostly gets paid when disease is already present. You get paid for the scan. You get paid for the procedure. You get paid for the admission. You get paid for the medication after the diagnosis. You get paid for managing the complication. What is much harder to get paid for? The long, boring, patient, relationship-based work that reduces the odds that someone needs all of that later. Not impossible. There are value-based models trying to do it better. There are primary care groups, community health systems, and public health initiatives making real attempts. But structurally, the default American system still rewards downstream intervention more reliably than upstream prevention. And when you combine that with very high prices, heavy administrative costs, fragmented insurance design, and weak coordination across sectors, you get an engine that is very powerful, very expensive, and often pointed at the wrong stage of the problem. That is why I keep coming back to this phrase. We have built the best sick care machine in the world. That is not the same thing as building the healthiest society. Let me make that more concrete. Imagine two 50-year-old patients. The first develops prediabetes, gains weight steadily for 10 years, sleeps badly, is stressed, moves less every year, and cannot get consistent primary care. Nobody meaningfully intervenes until the labs are ugly, the blood pressure is high, the joints hurt, the energy is gone, and the prescriptions start stacking up. The second gets earlier coaching, better follow-up, clearer nutrition support, better behavioral health access, and a community environment that makes movement easier and processed food a little less dominant. The first patient generates far more healthcare spending, more visits, more imaging, more medications, more specialist referrals, more complications. The second patient may generate less spending, at least in the short term, because less disease has matured. If you build a system that is paid more reliably for patient number 1 than for creating more patient number 2 outcomes, you should not be surprised by what the system becomes. That is not a moral failure of individual clinicians. It is a design problem. Now let's make this local, because if this conversation stays national, it becomes abstract, and abstraction is where accountability goes to die. Southern Oregon lives with a lot of the same upstream problems, plus a few regional amplifiers. We have an older population than many metro areas. That means more chronic disease burden and more pressure on Medicare-funded care. We have real access shortages, especially in mental health and primary care. We have lower household incomes than many wealthier urban corridors. That matters because lower income usually means less margin for healthy food, fitness, time off, transportation, childcare, and preventive follow through. We also have a healthcare market with limited competition. Asante is the dominant regional hospital system, which means the region depends heavily on how well one major institution performs, how it prices, and what it chooses to prioritize. At the same time, Southern Oregon has real strengths. We have parks, trails, outdoor culture, a scale of community where institutions actually know each other. Employers, clinicians, local governments, and nonprofit leaders can still sit in the same room here. That matters. Because one reason I am more optimistic about regional change than national change is that local systems can sometimes coordinate in ways national systems cannot, but only if they decide to. Oregon has a strong health conscious brand. Outdoorsy, progressive, nature rich, active. Some of that is real, but the data has not consistently matched the image. Oregon has long struggled with chronic disease burden, substance use, smoking, and obesity at levels that do not fit the national stereotype people have of the state. One OPB report described chronic disease as an $8 billion a year problem in Oregon, with more than half of Oregonians living with some form of chronic disease. And Southern Oregon often fares worse than the state average. If you live in Medford, Grants Pass, Ashland, Phoenix, Talent, or the smaller communities around them, that likely does not feel abstract. You can see the pattern. You see long waits for certain specialists. You see primary care access that can feel fragile. You see employers squeezed by premium costs. You see people delaying care because they are uninsured, underinsured, or simply overwhelmed. You see addiction and mental health struggles show up in families, schools, and emergency departments. And you also see something else. You see a region that talks a lot about healthcare because healthcare is one of the local economy's major realities. It is a major employer, a major cost center, a major source of stress, and for many families, a major source of confusion. That should get our attention. Because the mismatch between brand and reality can make a region complacent. If you think of yourself as a healthy place, you may underreact to the actual burden accumulating underneath the surface. I do not want this episode to just be a rant. If you are listening as an individual, here are the practical takeaways. First, stop assuming that more medical spending automatically means better health. It often means more treatment intensity, more technology, and more complexity. Sometimes that is exactly what you need. Sometimes it is life-saving, but it is not the same thing as strong population health. Second, pay attention to the upstream risks before they become downstream bills. That means asking some boring but powerful questions early. How is my sleep? How is my weight trajectory over the last 5 years, not just this month? How often am I moving? How much of my food is built around convenience rather than quality? How much alcohol am I drinking? Am I dealing with depression, anxiety, or chronic stress that is quietly driving everything else? Do I actually have a primary care relationship, or am I just reacting to crises? Third, if you already have chronic disease risk, do not wait for it to become dramatic. Ask your clinician more specific questions. What are my biggest modifiable risk factors right now? Which one or two changes would give me the biggest return over the next 12 months? What screening am I overdue for? What is the clearest marker we can track so I know whether I am getting better or worse? If cost is a barrier, what is the most efficient next step instead of doing nothing? That is decision support. That is how you move from vague worry to useful action. And if you are a parent, I would add one more layer. Do not think about this only as your own future medical bill. Think about the health trajectory your household is normalizing. Are meals mostly built around convenience because life is overloaded? Understandable. But notice it. Is movement built into the week, or is exercise treated like an optional luxury you never quite get to? Notice that too. Are sleep, screens, stress, and emotional burnout quietly shaping the whole family physiology? That counts a lot. The goal here is not perfection, it is earlier awareness. Because the earlier you notice the pattern, the less likely you are to meet it later as a diagnosis with a copay attached. Now let me shift from individual action to regional responsibility. Because this is not just on individuals. If we frame it that way, we miss the system. Here is my view. 1. Health systems should publish outcome goals, not just activity reports. If a health system dominates a region, it should not only report how much care it delivered, it should also report whether the region is getting healthier, not just how many visits happened, not just how much community benefit spending was logged, but whether diabetes prevalence is improving, whether avoidable admissions are declining, whether blood pressure control is improving, whether patients are getting primary care sooner, whether maternal and infant outcomes are improving. If we only measure activity, we will keep buying activity. 2. Employers should treat healthcare cost as an economic development issue. This is not just a hospital issue. It is not just a government issue. Every premium increase that hits a Southern Oregon small business reduces hiring capacity, wage flexibility, and resilience. So chambers of commerce, regional business alliances, and large employers should be much louder about healthcare cost drivers, not in a performative way, in a serious way. Ask what is driving regional premiums. Ask where competition is weak. Ask how chronic disease burden is affecting claims. Ask which prevention models are actually reducing spend over time. 3. Local planning should be treated as health policy. If you want healthier communities, think beyond clinics. Walkability is health policy. Food access is health policy. Safe public spaces are health policy. Transportation is health policy. Mental health access is health policy. If the easiest default in a community is isolation, sedentary behavior, ultra-processed food, and reactive care, then chronic disease should not surprise us. 4. Primary care and behavioral health have to be strengthened together. A region cannot manage chronic disease well while treating mental health as a side issue. Depression, trauma, anxiety, addiction, poor sleep, and chronic stress are not separate from diabetes, heart disease, obesity, and pain. They are tangled together. So if Southern Oregon wants better long-term outcomes, integrated primary care and behavioral health is not a nice extra. It is core infrastructure. 5. We need a better public conversation about prevention. Prevention is often talked about in one of two useless ways. Either it becomes vague wellness language with no operational teeth, or it becomes moralizing. People should just do better, eat better, move more, try harder. Neither is enough. Real prevention is practical. It asks, what friction is keeping people from taking basic healthy actions? What incentives are making the unhealthy default easier than the healthy one? What support can be delivered earlier, more cheaply, and more locally? What could employers, schools, health systems, and city planners each change within the next 12 to 24 months? That is a much better conversation than just telling people to care more. I want to say something about tone because this topic can slide into despair very quickly. Yes, the machine is expensive. Yes, the incentives are messy. Yes, the trend lines are worrying. But this is not a hopeless story. It is a clarifying story. If you misdiagnose the problem, you chase the wrong solutions. If you think the answer is simply spend more on healthcare, you will keep feeding the downstream machine and wondering why the upstream drivers stay in place. If you think the answer is just people need more discipline, you will ignore the structures that make healthy choices much harder for many families. The useful position is in the middle. Personal responsibility matters, and system design matters. And if we are honest, both have to be addressed at the same time. And for clinicians listening, I think there is an especially important takeaway. Many of you are practicing inside structures you did not create. Short visits, burdensome documentation, insurance friction, fragmented referrals, financial pressure to stay productive. I get that. So this is not a blame the doctor monologue, but it is an invitation to think bigger than the visit in front of you. If enough clinicians in a region begin naming the same upstream realities clearly, and enough employers, local officials, and community organizations hear the same message repeatedly, that starts to change what the region considers normal. And that matters. Culture shifts before budgets do. Budgets shift before infrastructure does. Infrastructure shifts before outcomes do. That is slow, but it is real. The one thing to remember. If you take one thing from this episode, let it be this. America does not mainly have a healthcare spending problem. America has an upstream health creation problem and then spends enormous amounts of money managing the damage downstream. That is why we can spend so much and still die younger. And that is why regions like Southern Oregon need a strategy that goes beyond hospital care alone. Because the point is not just to understand the machine. The point is to build something better upstream before crisis forces the conversation. This podcast is investigative health journalism for educational purposes. It is not medical advice. I am speaking as a clinician journalist and healthcare advocate, not as your personal doctor. Some of the evidence in this space is evolving, local data can change, and individual decisions should be made with a qualified clinician who knows your situation. If you see an error, or if you have local insight that would strengthen this work, reach out at reimagine-healthcare.org. Thanks for listening to Reimagine Healthcare. Until next time.